do we need to scan everyone with alopecia, aplasia cutis congenita? And so Albert Yan team suggested that if these 4 signs are present, then only we need to consider. And they went through their sort of a cohort of nearly 90 patients in the last 7 years. They have got a tertiary center and looking at, you know, if there is a hair collar sign, vertex location, which is very typical, which is the classical textbook picture, but unfortunately diseases haven't read the textbook, so they can come in different forms and shape, and more than 5 centimeter or vascular stains or nodules. Then if the child is, if you are seeing them sooner, so you can do ultrasound. If you are seeing them slightly later in life, after 6 months, you can do an MRI scan. Otherwise, there is no justification, and that's what they publish. Now, coming up to, again, something from Dr. Yasmina Khan. I'm you know, very much into education. So you can see pediatrics or dermatology, and this was a study for pediatric residents and their understanding of atopic eczema. And it was found that online education does help. The reason I've put it up here, because I was involved in one of the sort of educational activity at Imperial College, where I work 1 day a week. And this is the website they have created, Itchy Sneezy Wheezy, and it's free, so you can access it here. PGs, but even if you have educated families, you can they can access this. There are videos, there are so how to put the creams on, what to do, sort of how to do wet wraps, and basic information about eczema and allergy in children only. Now, in the same time, there was some publication about 1% propranolol for pyogenic granuloma. So you would have heard Dr. Syed mention about you know, the laser treatment and other options. Pyogenic granulomas can also be treated with topical agents. People have previously wrote up case reports and case series with topical timolol, but this is the first one with 1% topical propranolol under occlusion. So, you know, that's another option we have. Obviously, the ointment was made slightly specially. It was the tablet was actually broken down and then added on to 100 gram of the ointment. So it was mixed. So it was in-house made. So if you have a pharmacist who is very into making the local ointments and remedies, they can actually do that here as well. And that's the reason I put it on. And you can see the outcome reasonably well. So rather than putting a child through the surgery or laser or other options, this is probably the sort of most child-friendly option, I would say. Now, Chinese did something else. They looked at infantile hemangiomas, but for a non-selective beta blocker, which is cartilolol, and they found that it does work as well. And it actually, they were using it since 2012, and it's interesting to see they have used it for 6 months rather than longer, because obviously for propranolol and other options, when we give them systemic, we give them slightly longer. And obviously their study was quite intense, because they had to do ultrasound, blood glucose, echocardiograph. So they did a very thorough selection of patients and investigations to find out whether it is safe, and it seems it is safe and effective both. And this is again one of their, you can see it will not completely resolve it in some cases where it is extensive, but most of the time their outcome was better. On head and neck, the outcome was better. You can see the efficacy rate was 99%. This pointer is not working, but that's fine. So you can see the second presentation here on this graph, this table, and 99.2% was. So head and neck is much more receptive rather than the arms and leg. Now in March and April, this was alopecia registry data, again suggesting, and the reason I put it on here, you can see this is quite a nearly 2,000 patients, more than 2,000 patients actually, and you can see most of them were either alopecia areata universalis or totalis, but there was a bit of alopecia areata simplified as well. And there are associated diseases with alopecia, so it doesn't come alone. It has other atopic eczema and sort of allergies, urticaria, vitiligo, so because of the autoimmune profile of the disease itself. Now, coming up to hyperhidrosis, that was published again in this March-April time. Oxybutine in 3% gel works fantastically well. So more and more options are available for us in pediatric dermatology, and you can see, this is pediatric, as well as you can see some patients were 20 and 21. But the reason they added on because the patient was under the follow-up for other topical options or other treatment options since they were a pediatric age group. And so this is what I mentioned about topical timolol, and I think I presented in my previous slide as well. The question is, what is the dose? Because at the moment it's expert consensus. Another group of researchers from states, what they suggest and what they have gone through their patients is patient weight in kilogram. Again, this is 0.5%, which we use anyway as an expert consensus in the pediatric dermatology with regards to the infantile hemangioma. And they say 1 kilogram of body weight is equivalent to 1 drop. And they have done the calculation. So for example, a 4 kilogram child should receive a total daily dose of no more than 4 drops. So you can break it up, either 1 drop 4 times a day, 2 drops twice a day, whichever way, but at least you know how much you have to give. What is the safety net there? So May, June, you can see alopecia again, hydroxychloroquine this time, and retrospective 9 pediatric cases, and works fantastically well. And these are all the details of the patients, and they had other options, but the reason I've put this one on, you can see most of them had 200 milligram twice a day, regardless of what age of they were, so between 6 and 16. Now, Molluscum contagiosum, I think Dr. Yasmina Khan showed a photograph as well for Molluscum, and there are different options available for Molluscum. Some people do curettage and cartridge as well, and there are other options, but the least invasive option is topical use of medications. We have Molluscum in UK, which is 5% potassium hydroxide licensed, but we do use sodium agents as well, sodium-based agents, and this is potassium hydroxide 10 and 15%, and with a placebo, and 10% was as effective as 15%. So possibly the Molluscum, the company behind Molluscum, is going to increase the strength from 5 to 10, because with 5% we have to give multiple treatment options, so multiple treatment cycles, and it doesn't work that well. So this is an update from on that regard. July and August, you can see alopecia areata again. Has the child got celiac disease? Because there is extensive research about this. Is alopecia associated with celiac? But this was a sort of a much broader review of the literature, and what they suggested that alopecia areata was not specifically recognized as a risk factor sufficient for routine testing. But if somebody is not responding to the treatment options, then yes, do consider that as so it's not a routine testing, but it's one which we have to consider if we are not winning. Now, something close to my heart, topical sirolimus. It's been sirolimus is part of it's a magic treatment. I have presented previously on sirolimus as well. I wouldn't go into detail, but it was the discovery of sirolimus. If any of you have interest, just Google it and you will find it out. How it was isolated from the soil of Rapamyr, which is the islands, Easter Islands, and that's where the name rapamycin or sirolimus comes from. But this is a topical agent, and you can see it works fantastically well for vascular anomalies, and this is a case series. So this is another update on that. Rather than for the mild options, you can actually use this as well. And 0.1 or 0.03, very few people will have access to, but it's 0.1 which we normally use. And you can see it will not completely resolve it, but it will improve it. And obviously these are sort of case series, case reports, just sort of making a base for the longer and bigger study. Now this is another thing, ichthyosis. Ichthyosis, very few options for us. It's a genetic skin condition, and when I was at Great Ormond Street, we did tried using this as well, NAC, and you will see N-acetylcysteine. But the reason I've presented it here is because you can see even Americans are saying the bulk cost of NSA is very low. Again, you need a very good pharmacist. It smells pretty rubbish. So if you open a box of NSC, it smells very bad. So that's the reason I think I've got it here. So they've added on to the rosemary oil, but I think we tried in rose suspension as well in Great Ormond Street. Still, it smells a bit. But it works fantastically well as a topical application. Minimal side effects apart from local irritation, and the life of an ichthyosis child you will change. And I'm sorry to say, but most of my ichthyosis patients in UK are Pakistanis. So you have to think about, and that's what I think when I sit in my clinic. If I'm seeing so many Pakistani patients with this condition here, there must be a lot more in Pakistan. September and October. So all of us know this is hemangioma. Do we need to treat it? If yes, what are the options? What we have to look for? So risk factors for ocular complication in periocular infantile hemangioma, and you can see if it is diameter is greater than 1 centimeter, if there is a deep component or upper eyelid involvement, then obviously we have to refer the child to the ophthalmologist, and treatment is strongly considered. Now another thing, education with regards to the pediatric dermatology in the United States. This is just a comparable study, and the reason I've put it on here because roughly the literature tells us for one inpatient in pediatric dermatology, we roughly see between 25 to 40 outpatients. So if there were 74,229 inpatients in states in 1 year, that is 2012 obviously, then so they would have roughly, you can multiply it roughly to 30, so 3 million, just under 3 million outpatient consultations. And so just replicate that to Pakistan as well. So our pediatric population is missing out on a lot if we don't have purposeful training in pediatric dermatology. And obviously we have to look for our country. So just this is a thought-provoking idea, just I wanted to put it up here. Now in November, December, you can see again alopecia areata, but this time it was anthralin. It's 0.5 for 10 minutes, or it was 1% topical, and again it was for starting at 10 minutes, but then going up to a maximum of 30. And you can see that the response was significantly good, especially the 100% scalp regrowth. It was one third was between 50 and upwards from 50 to 99. So it was more than sort of 70% respond more than 50%, which is quite good for a patient population, which sometimes we don't have very much options safely. And this is another parallel publication where you can see anthralin was used but with leflunomide, and this is potentially because we know in adults JAK inhibitors are now licensed for alopecia, and obviously they are hugely expensive, and even in UK we are not using it at the moment because of our National Institute of Clinical